Welcome, everyone. Thank you so much for being here this evening, Wednesday night of the San Antonio Breast Cancer Symposium. So pleased to see you here for key steps to success with CDK4/6 inhibition in early through metastatic hormone receptor positive HER2 negative breast cancer. We'll be talking about stratification, selection, sequencing, and specialty management. And this symposium is provided by PVI, Peer View Institute for Medical Education, and supported by an educational grant from Lilly as well as Novartis Pharmaceuticals. And moving on to our amazing faculty who are here with me. I'm Dr. Sarah Hurvitz. I'm a medical oncologist specializing in breast cancer, currently at the University of Washington Fred Hutch Cancer Center. I'm so pleased to be joined tonight by Dr. Kamel Hussein, Assistant Professor of Medicine at the Cooper Medical School of Rowan University, co-director of the Janet Knowles Breast Cancer Center, and Director of Breast Medical Oncology at MD Anderson. Welcome tonight.
Thank you so much.
And also my esteemed colleague, Dr. Carlos Barrios. Okay, help me here, Carlos. Grupos Oncoclínicas.
Perfect. I didn't know you spoke Portuguese.
The Latin American Cooperative Oncology Group. We've worked together for many years, and it's so really great to have you here tonight.
Thank you.
And Dr. Eleonora Teplinsky, Clinical Assistant Professor of Medicine at the Icahn School of Medicine at Mount Sinai, New York. So happy to have you here tonight, Dr. Teplinsky. All right, so thank you so much to PeerView and to Living Beyond Breast Cancer for providing this session, Lilly and Novartis for support. If you haven't already done so, please complete the pre-event survey. This will really help us as we do the post-event survey to see what is learned. And please do engage with us. Participate in polling throughout the session. Submit your questions for the Q&A segments. We prefer to have your questions submitted. We have so many online participants tonight, I think 150. So welcome to all of our online participants. So it's much easier for everyone to hear if we submit our questions virtually rather than having us use the roaming microphone. And then visit us at peerview.com at this web address. You can find the slides and the practice aids, access and the activity menu right now, and you can download them after the session, and you can join the conversation on social media as shown here. We want to extend a special thanks to Living Beyond Breast Cancer, our patient advocacy partner. LBBC provides trusted information and a community support to all patients with breast cancer. You can download supplemental resources made available as part of this activity, and you can learn how you and your patients can access support through LBBC. All right, so our goals today. We want to learn why it is important to recognize the varied spectrum and different subpopulations of patients within the hormone receptor positive breast cancer subtype, identify patients who would benefit most from the use of CDK4/6 inhibitor-based therapies in both the curative and advanced disease settings, identify what the key factors are for optimal selection and use for CDK4/6 inhibitors, and how to maximize the benefits and minimize the risks of CDK4/6 inhibitors and combinations through effective team-based care and patient education and management. And before we move into our first discussion, we'll do a couple of questions. So please scan to answer this question that I will read to you. In your opinion, which of the following represent key practice challenges in hormone receptor positive, HER2 negative, early breast cancer, and metastatic breast cancer? 1, risk assessment and stratification and identification of patients who would or would not benefit from different treatment strategies. 2, navigating the nuances of optimal treatment selection and sequencing throughout the disease continuum. 3, understanding and addressing the development of resistance and the changing disease biology. 4, maintaining quality of life and minimizing treatment toxicities while extending maximum treatment benefit to all patients. And 5, all of the above represent challenging areas in which more data and practical guidance are necessary. So please vote. Okay. Not surprisingly, all of these do represent challenges that we face and face on behalf of our patients. Excellent. Okay. And then we have a case just to get your brain juices working here. So we have Diana P. She's 58 years old, postmenopausal. She's a music teacher, married, one son, very active. She travels a lot and no notable comorbidities. She has a screening mammography that detects a left breast mass that's 3.5 centimeters with enlarged suspicious axillary lymph nodes. A biopsy shows grade 3 invasive ductal carcinoma, ER and PR positive, and HER2 1+. A sentinel lymph node biopsy by core needle shows cells consistent with, so actually just an axillary lymph node biopsy shows cancer. She has staging scans that show no distant disease, and her germline BRCA testing is negative. She undergoes a left mastectomy and sentinel lymph node biopsy. 1 out of 4 lymph nodes are positive for macrometastasis. She has a 3.5 centimeter tumor that's grade 3, and an oncotype DX is 28. So she was seen by her breast surgeon for a follow-up appointment 2 weeks after surgery, and now she's coming to her medical oncologist 3 weeks after her surgery to discuss her results and next steps. How would you categorize Diana's risk of recurrence? She had 1 lymph node positive, 3.5 centimeter tumor, grade 3, and her oncotype was 28. What treatment would you recommend? 1, she's intermediate risk of recurrence, and you'd recommend an adjuvant AI, but no CDK4/6 inhibitor or chemotherapy. 2, intermediate risk, adjuvant CDK4/6 inhibitor with AI, but no chemotherapy. 3, high risk of recurrence, adjuvant CDK4/6 inhibitor and AI, but no chemotherapy. Or 4, high risk of recurrence, chemotherapy and adjuvant CDK4/6 inhibitor with AI, or 5, I'm not sure. Please vote. Okay, good. I like the wobble. I like the distribution. That means that we can have a robust discussion tonight and help inform this sort of assessment. No really incorrect answer here. We made it a little bit challenging, but clearly we have some discussion to be had. So with that, we're going to move on to Dr. Hussein, who's going to talk about risk stratification and treatment selection in early stages.
Thank you so much, Dr. Hurvitz, for the nice introduction, and thank you everybody for coming. I'm really happy to be with you here tonight. So to set the stage, I chose to start first with some real-world data, which usually helps us understand the scope of the problem and the risk that those high-risk early-stage hormone receptor positive patients face. And so if you look here, you're going to see the upper curve is focused on OS. The lower curve is focused on IDFS. The blue curve is representing the non-high-risk patients, early-stage hormone receptor positive disease. The red curve is the high-risk patients that are node positive. And for context, in this real-world data, they did include early-stage triple-negative disease as a comparator arm. And you can see that the curves are overlapping for OS and IDFS over 5 years. So it's a really high-risk group. When looking at breaking them into non-high risk again, which is the blue curve, and then the high-risk disease, breaking them down by the number of lymph nodes that are involved. So you're going to see three different curves, N1, N2, N3. You can see that as the number of lymph nodes involved goes up, the overall survival is worsened and the recurrence risk is also worsened. And then the last one, which I find very helpful, is N1 high risk versus N1 non-high risk. So not every node-positive patient carries the same risk of recurrence and diminished survival. So you can see that there is a significant difference between the two groups. So this is some real-world data also from the Flatiron database that looked at patients from 2011 until 2020, and it broke them down by the presence of, you can see, 10 or more positive nodes with a 35% recurrence risk at 5 years, 4 to 9 positive nodes, 33.7%, and patients who had 1 to 3 positive nodes with high-risk features, and that was defined as a large tumor more than 5 centimeters or a grade 3 tumor with a risk of recurrence of more than 26%. And when they compared that at the very bottom of the table, the node negative or patients with 1 to 3 positive nodes without high-risk features, you can see that the risk is pretty standard, about 8.6%. So it's agreed upon from this data and from prior data that nodal involvement, so as you can see here, the risk factors are nodal involvement, number 1, number 2, having a high-grade cancer, number 3, having a large tumor more than 5 centimeters are the definitive high-risk features. But in addition to that, we do see that other high-risk features, including a high Ki-67 more than 20%, or an elevated genomic risk. I would like to call your attention to a poster that was presented earlier today, and this looked at the way that patients look at their diagnosis and how they prioritize the information they receive from their providers when they are diagnosed with early-stage disease. And this was a survey that included patients with different subtypes of breast cancer, including the high-risk hormone receptor positive. About 30% of those patients, unfortunately, ended up with metastatic disease. And patients really did prioritize receiving information that discusses how to reduce risk of recurrence at the time of diagnosis. And in this survey, they did report that there was significant lack of information and emotional support at the time of diagnosis. There's a lot of trials that looked at the use of CDK4/6 inhibitors in the early stage high-risk population. In the very beginning here, we see the Penelope-B and the Palace trial. Both of them used palbociclib for a period of 1 year and 2 years, respectively, and both of those were negative trials. So we're not going to focus on those. Our focus mainly is going to be on the Monarchy trial, which used abemaciclib for 2 years in the node-positive population, and the Natalie trial that had a little bit of a broader inclusion criteria, and that used ribociclib for a total of 3 years. Both of those were positive trials. The first one is the Monarchy trial, which was a very large trial, more than 5,000 patients. And here patients were broken down into two different cohorts. Our main focus is going to be cohort number 1, which included 91% of our patients. And that is the cohort that led to the FDA approval. So you can see here that the inclusion criteria were 4 or more positive nodes or a positive lymph node, provided that there was a high-risk feature, either a large tumor more than 5 centimeters or grade 3 cancer. They took those patients and they broke them down into 1-to-1 of either receiving standard of care endocrine therapy or endocrine therapy plus abemaciclib for a period of 2 years in the adjuvant setting at the standard dose of 150 milligrams PO BID. And then after that, the patients continued on with their endocrine therapy, monotherapy for 5 years, 10 years, based on what was deemed to be medically appropriate. The majority of those patients, because of their nodal positivity, did receive chemotherapy, so about 95% of patients. And the primary endpoint was invasive disease-free survival, and the key secondary endpoints were disease recurrence-free survival and overall survival. And here I listed the primary endpoint and the key secondary endpoint of IDFS and DRFS. And you can see that following the analyses from 2, 3, 4, up to 7 years, which was recently presented in ESMO of this year, we can see that the delta is quite maintained and even gets bigger over time. So for IDFS here, we see that at 7 years, there was a significant delta of about 6.9% with a hazard ratio of 0.7. The disease recurrence-free survival, which to me, I put a lot of value on that because this is when the patient becomes metastatic with distant mets, incurable, and committed to treatment for the rest of their lives. I find it to be a major loss to lose a patient to that endpoint. And at 7 years, the delta was 5.5%, again, with a very significant hazard ratio of 0.7. So the benefit really from the addition of abemaciclib in this population was about a 26-27% reduction in risk of recurrence and risk of distant recurrence. And it's important to note that at this time of the analysis, all of the patients on the trial were off abemaciclib for 4 or more years. The key secondary endpoint of OS was also discussed in the conference at ESMO. And here we've seen that the analysis at 5 years, 6 years, and 7 years, the delta kept getting bigger. It is a modest difference. However, at 7 years, it was 1.8% with a hazard ratio that was 0.84. This was for the ITT population. But when we look at cohort 1 is the cohort that led to the FDA approval. You're going to see that the delta was a little bit more pronounced at 2%. So that translates into about 16.5% reduction in risk of death based on this hazard ratio. The subgroup analysis here, you're going to see that patients benefited from the addition of abemaciclib, regardless of whether they were older, above the age of 65, below the age of 65, regardless of menopausal status, whether they received neoadjuvant or adjuvant chemo, regardless of the number of lymph nodes involved, the size of the cancer, the grade of the cancer, stage of the cancer, and the endocrine partner that was used. And here, those two blocks are comparing the abemaciclib and endocrine therapy versus endocrine therapy monotherapy alone. And here in green, you can see the number of patients that are alive with metastatic disease. So there was 30% less patients alive with metastatic disease in the abemaciclib arm. The blue are patients that unfortunately died. Light blue, death due to breast cancer, again, less in the abemaciclib arm compared to the endocrine therapy arm. And the dark blue is deaths due to other reasons. The decreased number of patients that are alive with metastatic disease is what is expected to drive a larger benefit in OS over longer follow-up. There was another abstract that was presented earlier today that looked at the subgroup analysis by nodal status. So they broke down the different endpoints that we just discussed, IDFS, DRFS, and OS, by N1, N2, and N3 disease. And you can see that the hazard ratio is quite maintained and similar in all the different subsets. And it's also worth looking at the delta here. You can see that the delta keeps increasing as the risk of the patient increases by the number of lymph nodes involved. So here, when you look at the OS improvement, the delta was 1.4% for N1, 1.6% for N2, and 2.7% for N3. The second trial is the NATALEE trial. And NATALEE did include a very similar patient population, but it added patients that were node negative with high-risk features. So that included stage 2A patients that were node negative, either with a grade 3 cancer or cancer that was grade 2, provided that they had an elevated Ki-67 of 20% or more, or an elevated oncotype. And here, the patients were randomized in a 1-to-1 fashion again to either receiving a non-steroidal AI versus a non-steroidal AI plus 3 years of ribociclib at the intermediate dose of 400 milligrams daily for 3 weeks on, and then took a one-week break. And that continued for a total of 3 years. The primary endpoint here was IDFS, and the key secondary endpoints were recurrence-free survival, distant disease-free survival, OS, and quality of life metrics. The primary endpoint here with IDFS over the 5-year analysis, which was also recently presented at ESMO, we did see a delta of 4.5% that translated into a hazard ratio of 0.71 with a significant p-value. And at this time of the analysis, again, all patients were off ribociclib for a median of 2 years. That's quite reassuring. They also presented data by N0 versus N plus disease. And here we can see that the magnitude of benefit based off of the delta that we're seeing was maintained and even more obvious in the node negative with high-risk features. So it was 4.4% for the N plus disease, and it was 5.7% in the N0 with high-risk features. Again, hazard ratio of 0.60. The key secondary endpoints, including distant disease-free survival and distant recurrence-free survival, was also noted to improve by an average of 4.3% delta with a hazard ratio in the same range of 0.70. Tomorrow there is going to be a poster presentation that will look at the 5-year analysis of the distant disease-free survival for the key subgroups of the NATALEE trial. And we can see here from the breakdown of the different stages that the amount of benefit gained from 3 years of adjuvant ribociclib was maintained in all the different subgroups. Regarding OS, we don't have mature data yet, as at the time of this analysis, only 7% of the events happened in both arms. So still early, but it looks positive and it's moving in the right direction with a difference of about 1.6% at 5 years with a hazard ratio of 0.80. But only time will tell. This is a comparison between the two different trials, and as we discussed earlier, Monarchy was a node-positive only patient population. The NATALEE did include a node-negative high-risk group. So that's really the key difference whenever I'm thinking about the difference between the two trials. So even patients that have larger tumors, so patients that are T3 and 0, T4 and 0, they were not eligible for inclusion in the Monarchy trial, but they were eligible for the NATALEE trial. So whenever we have a new intervention, we try to look back, again, real-world data to try to see how well are we doing. And in this year in Miami Breast, they presented this interesting real-world data that looked at patients who would fulfill the criteria for adjuvant abemaciclib. And that was from more than 250 US institutions. And surprisingly, they were able to see that only 40% of the patients did receive adjuvant abemaciclib, and 60% of patients did not receive abemaciclib. They did go on to outline the different parameters where they saw a discrepancy between the two different sites, and that included patients with N1 or N1 MYC disease. N2 and N3, there was not much difference. There was consistency in opinion that they're high risk enough. Patients that were above the age of 65 received less recommendations for adjuvant abemaciclib, and Hispanic population compared to other ethnicities. They did not see any difference regarding the insurance status, whether they were treated at an academic versus a community setting, and socioeconomic index status did not make a difference either. So, oral SERDs. Big news today from the lidERA study, and probably it would lead to a practice change. But lidERA is not the only trial that would impact this field of high-risk early-stage cancer. There are many ongoing trials using camizestrant, imlunestrant, elacestrant. So here you can see different models of design. You can see the EMBER-4 and ELEGANT after 2 to 5 years of endocrine therapy, and they allowed CDK4/6 inhibitors. Patients get randomized to standard of care endocrine therapy monotherapy versus an oral SERT as a monotherapy. Cambria-1 and Cambria-2 did focus on camizestrant, either alone or in combination with abemaciclib and lidERA, of course. So the lidERA trial that was presented earlier today did include patients that were stage 1, 2, and 3. They included patients that were even node negative, provided that they had at least a centimeter cancer that was grade 3 or high Ki67 or a high genomic risk, or patients that were node positive. They included about 40% premenopausal patients, so that there was good representation there. They took all of those patients from the beginning of their adjuvant therapy and broke them down in a 1-to-1 fashion to either receiving standard of care endocrine therapy versus giredestrant once daily. And their primary endpoint, again, was IDFS. Key secondary endpoints were DFS, DRFI, and IDFS in other subgroups, along with OS. And here we can see that the primary endpoint with IDFS, where we've seen a significant improvement in IDFS over a little over 2.5 years follow-up, so really quite early results, but very impressive with a hazard ratio of 0.70. So there was a 30% improvement in the chances of avoiding development of recurrent disease from the use of giredestrant versus the use of an AI or tamoxifen. Definitely, when you look down here, you're going to see the benefit was much more larger when they compared it to the tamoxifen group compared to the AIs. Side effect profile was quite reassuring on both sides, so we really did not see any major differences. However, I think we can all agree that musculoskeletal problems from the use of AI is a big concern. So when you look at the reason for discontinuation of therapy, you're going to see that less discontinuation was happening overall from the giredestrant arm, and the discontinuation regarding musculoskeletal disorders was much less. It was about 1.6% in giredestrant arm and 3.7% in the standard of care endocrine therapy. Bradycardia was another side effect that was discussed. It's quite reassuring to see that the majority of cases were grade 1, which is asymptomatic bradycardia that is just incidentally picked up. It's something that you probably don't have to interrupt dosing or reduce dose for. And of course, there was more venous thromboembolism on the standard of care endocrine therapy arm, probably due to the use of tamoxifen. So at this point, we're going to go back to our case discussion, and I'll hand it over to Dr. Hurvitz.
Excellent. That was a beautiful presentation. Thank you so much. So let's go back to this patient. We'll answer the question, but then I think we should have a bit of a discussion. So again, Diana is 58. She has a 3.5 centimeter high-grade ERPR positive, HER2 negative breast cancer, no distant mets and no germline mutations. 1 out of 4 lymph nodes are positive for a macrometastatic focus, and her oncotype is 28. So let's understand her risk status based on these presenting features and findings. How do you explain, and Kamel, you work in the community, so you're not dealing with the typical academic medical center patient who may search you out, but you've got a robust and heterogeneous patient population. How do you explain risk of recurrence to patients, because this is sort of an unmet need as you presented, and relative improvements versus absolute improvements with new therapies?
Absolutely. I find the table that we discussed earlier in the presentation that broke patients down by nodal status to be very helpful in getting percentages that I can possibly use in my discussion with my patients. So we've seen that patients that have 1 to 3 positive lymph nodes with a high risk feature, they run about a 26%, if not higher, because this patient has also a very high oncotype. It's about 26. So that increases the risk. So she has a grade 3 cancer. She has 1 positive lymph node. Her cancer is less than 5 centimeters. So usually I would discuss with her that she has a probably 1 in 5 chances of getting disease recurrence over the next 5 years. And then we talk about the benefit that we have seen from IDFS, DRFS. Now we have a survival benefit, so we can include that in the discussion. And I translate the hazard ratio into a percentage, and that makes it a lot more easier for patients to grasp the meaning of what that intervention would, how that intervention would impact the risk of recurrence in the future.
Absolutely. That's so important to be able to explain that to patients. These are very long conversations with our patients. Dr. Barrios, how do you talk about patients' risk of recurrence with ER-positive disease as a long-term risk that may not be fully represented by 5-year statistics?
I think that that's an extremely important point that we need to recognize. These are, in a way, very early results for all these trials, because we know these high-risk patients have a high risk of recurrence. But if you look at what happens as you follow these patients, in the first 5 years, you have only 50% of the recurrences. So you would expect after 5 years for these recurrences to continue to be seen. And if you look at the curves in general, okay, of previous trials, you see that in triple-negative breast cancer, for example, or HER2-positive breast cancer, after 2 or 3 years, the curves kind of plateau. In hormone receptor-positive disease, pay attention to the previous studies, the curves continue to drop down, okay, which make you think, what are we doing here, okay? Certainly we may be preventing some recurrences. I'm not sure we're curing a lot of these patients, okay? So certainly these trials are giving us early evidence that the combination of cyclin inhibitors plus endocrine therapy helps reducing the recurrence of these high-risk patients. We still cannot say for sure whether this is going to happen with late recurrences. We certainly expect that to happen, but I think for the follow-up is going to be required for that.
Yeah, absolutely. Following these patients long-term, we've seen we need to follow them out 15, 20 years to really appreciate the long-term impact.
The other important things are in this thing that both trials have demonstrated, as Kamal was showing, that there is this carryover effect, that you stop the treatment at 2 years or at 3 years, and the curves continue to separate with a persistent benefit of therapy. We know that from tamoxifen, and we know that for aromatase inhibitors. And in tamoxifen, for example, the long-term carryover effect extends itself to 10 to 15 years. Amazing, and still we do not know the biology of this phenomenon, okay? Why you stop treatment and the curves continue to separate? Why the benefit continues there? We don't know that. So it'll be interesting to know. What happens is that after some time, the curves become parallel. So maybe it's something that we're going to have to follow with these trials, because the curves may become parallel sooner, okay, in this group of patients. But still, as is being mentioned, we need to follow these patients further in order to find out what's happening with the long-term recurrences.
Absolutely. And Dr. Teplinsky, can you speak a little bit about the overall survival benefit and how it impacts your discussion with the patient about the two agents? So you have a patient like Diana who has 1 lymph node positive and is appropriate for both abemaciclib and ribociclib. So does that weigh into your decision, keeping in mind this long-term outcome and how the curves may continue to separate?
Sorry, yes. So I have lost my voice, so this is going to be fun. I would say that I think there's two ways to think about it. One, I think we have to keep in mind that the data from Natalie is not, it lags behind the monarchy data simply in the time points that these studies were conducted. So I think we have to keep that in mind when we're doing any cross-trial comparisons, and we just don't have that longer follow-up data yet for Natalie. But I think survival is important. And I think, we'll talk more about toxicity later on, but sometimes patients really are fatigued from all the treatment. And they're saying, all right, I've gone through all of these treatments, and now you want me to do 2 to 3 years of a medication. This is exhausting. These medications have side effects. And so I do think that showing a survival benefit and saying it's small right now, but again, we just have that short-term follow-up. So I think that the survival curves may continue to evolve with longer follow-up, but I do think it helps our patients kind of frame their decision-making in terms of choosing CDK4/6 inhibitors.
Yeah, those are really good points. I think we have to weigh the impact on quality of life while underscoring with our patients the importance of long-term benefits. So, Dr. Hussein, I think we'd agree this particular patient is a gimme. She's high risk for recurrence. So I don't think any of us would argue that she is appropriate to consider use of a CDK4/6 inhibitor. But I want to present a case, and it's not that uncommon in clinical practice. A lower grade, or maybe grade 2-ish, KI 67, 19%, invasive lobular carcinoma with 2 lymph nodes positive, evaded imaging. Oncotype DX is around 24. How do you feel about replacing chemotherapy with the CDK4/6 inhibitor, knowing that the majority of patients enrolled in Natalie and Monarchy had received chemotherapy? How do you balance that discussion in a real-world setting? We're not saying this should be NCCN guidelines. Right. This is the art of medicine.
Right. And how big is the cancer?
Let's say 4 centimeters.
Okay.
2 nodes, but lower. Let's go with low grade.
Right. So I think it's a discussion. It's an area that is not clear cut. I think there's always room for discussion. I always remind myself that, again, 95% of patients on those trials did receive chemotherapy in Monarchy. 88% of patients on Natalie did receive chemotherapy. When it comes to premenopausal patients that are node-positive disease, which by definition are going to get offered chemotherapy. I think we have ongoing trials like the Offset trial that's going to help us answer that question. But a case like this where things are so gray, I think it's a little bit of an unclear situation. I would favor using chemotherapy. But again, this is ILC. I'm not sure exactly how much benefit am I getting from chemotherapy. And I try to optimize endocrine therapy as much as possible.
That's a great answer. And I want to go to Dr. Barrios and see in your practice, how would you approach that?
I think that if you look at the evidence we have generated in the metastatic setting, there is a trial called Right Choice that actually looks at patients that have indication for chemotherapy, that have aggressive disease in the metastatic setting. And that compares a phase 2 trial that compares the use of ribociclib with a cyclin inhibitor with endocrine therapy versus chemotherapy, okay? And using in that trial combination chemotherapy, okay? And this is the kind of patient you see and actually have a visceral disease, very symptomatic. And in this group of patients, hormone receptor positive, there was actually a significant better result when you use the CDK4/6 inhibitor. So you can use this kind of strategy to treat hormone receptor positive disease that presents with the more aggressive features in the metastatic setting. Okay, that doesn't necessarily translate to the adjuvant setting, but it's fuel for the idea that we may be able to substitute at some point. Wouldn't it be nice for us to tell patients in the adjuvant setting, you do not need chemotherapy, we can treat you with pills I think that that would be a fantastic thing to tell our patients. So there are trials ongoing at the present time. We're starting a trial in South America with European colleagues called NOLITA, where we are addressing specifically this question of using chemotherapy or not in this kind of setting. And it would be fantastic if we can actually substitute the chemotherapy in this setting. So I think that there is evidence. We don't have clear data at the present time, but it's an important question for us to address.
Yeah, in so many situations, we find ourselves in a situation where we don't have data to guide our choices, and we have to do our
Many
best.
times.
Yeah, absolutely. Last question before we move on, and you can be brief, and it's a question with no correct answer, but we saw the lidERA data presented today, and patients enrolled in that trial did have higher risk disease. I mean, even those who are node negative and smaller tumors had to have higher risk features. So we may have giredestrant to use in the adjuvant setting. How are you going to apply these data in a patient who is also eligible for a CDK4/6 inhibitor?
Well, I think that's one of the big questions of the lidERA data. I think that the data is compelling. I know there were questions about cost and accessibility, but putting that aside, I think that if giredestrant gets regulatory approval, we will want to use it. And so how do we use that? I know there's a sub-study with CDK4/6 inhibitors as part of lidERA that was not presented today, but assuming we don't have that information, I think that's really going to be the question. Do we extrapolate from studies like Elevate in the metastatic setting and give giredestrant with the CDK4/6 inhibitor in, again, the paucity of any data? What was brought up in the discussion today was looking at, do we do an AI with the 2 to 3 years of your CDK and then do a switch to giredestrant? So I think these are questions that we really don't know yet. And I think in time, we're going to see some of the other CDK4/6 inhibitor the other SERD studies presented. I think that will evolve because some of the other SERD studies do have that combination with the CDK.
Excellent. Sounds great. Thank you so much. So, have you changed your mind? Please answer this poll again. We will go ahead and move on, but take a moment to answer a follow-up question related to this case. We won't be showing the answer. And I do want to acknowledge we've received several questions in, and I will get to them in our next Q&A, but I don't want to miss out on our presentation. And so we're going to move on to Dr. Barrios speaking about risk assessment and treatment selection and sequencing in advanced stages.
Thank you, Sarah. Pleasure being here. Thank you for the invite. What we'll do is look at some of the data that actually brought us to the adjuvant setting with this combination of cyclin inhibitors and hormone therapy. And I guess, Sarah, you're going to have to present the case.
Oh, okay. I will, but you could.
I could.
You
okay,
could.
Yeah, I could present the case. So Pearl is a 64-year-old lady that's retired, former stimulus, Taylor, married, 4 adult children. She has poor controlled type 2 diabetes and hypertension as comorbidities. She had received prior adjuvant endocrine therapy for hormone receptor positive disease, but developed recurrence within 12 months of completion of her adjuvant AI therapy. So this is an important part of her clinical history. So remember that. Within 12 months of completion of the adjuvant AI therapy. She has extensive visceral metastasis. She is symptomatic with abdominal pain and mild shortness of breath. She has a biopsy that confirms hormone receptor positive, 80% expression, a HER2 that is 1+, and the pathology is consistent with metastatic carcinoma with a breast primary. She has a family history, but no BRCA mutations were detected, and no other biomarker testing has been conducted. So within this context, the patient is coming for her medical oncology clinic appointment to discuss how we are going to manage this patient with metastatic disease in the first-line setting. So the questions are, next.
So what first-line therapy would you offer,
The
Pearl?
idea is that this endocrine-resistant patient, that's what I mentioned, that This patient had a recurrence within the 12 months of completion of her adjuvant therapy. And she has also to consider this poorly controlled type 2 diabetes. And assuming all these options are available for in your clinical practice, you have the combination of fulvestrant and CDK4/6 inhibitor. Remember, she had an AI as the adjuvant therapy, an AI and CDK4/6 inhibitor combination, imlunestrant plus abemaciclib. The patient may be tested, and if it is positive for PI3 kinase mutation, you could potentially offer her fulvestrant palbociclib with inavolisib, as we're going to discuss in a few minutes. T-DXd as an alternative, an ADC in this setting, first line, or you're not necessarily sure how to manage these patients in the first line. So you have the different opinions here. Some people would use fulvestrant. Some of you would still use an AI with CDK4/6 inhibitor. The combination of a new SERD with abemaciclib is something that some of you also considered. You see that there is a wide distribution, and all of you actually select some of these alternatives. You would consider the Inavo 120. The possible alternative there against that situation is the poorly controlled type 2 diabetes that we will address. And some of you would also consider the possibility of T-DXd. Let's move on to the discussion and see what evidence do we have in this kind of situation. So there is absolutely very clear evidence that was generating over the last few years that including a cycling inhibitor in the management of hormone receptor positive disease on top of our endocrine therapy brings us better results. But it's extremely important to consider that these patients are not necessarily the same. We need to identify different populations of patients with first-line metastatic disease. And you have the endocrine sensitive patient population. And some of the trials that I'm going to discuss with you actually looked at this specific population. And this population has recurrence more than 12 months after completion of the adjuvant therapy. So you remember that. The patient completes the 5 years of adjuvant endocrine therapy, spends 12 months without evidence of disease, and after that, 1, 2, 3, 4 years later, develops metastatic disease. This is what we call sensitive disease. In this kind of situation, there are a number of different trials that showed, in my opinion, a revolution. You look what happens in the orange bars. The PFS is around 14, 16, 14, 13 months. This is what we can offer these patients with standard aromatase inhibitors. If we add to this treatment a cycling inhibitors, look what happened. You double the PFS to close to 2 years, 24 to 30 months. It's an amazing result. You actually control the disease much better. So certainly, in my opinion, adding the cycling inhibitor represents a revolution in the management of this kind of patients. The other group of patients that our patient actually essentially applies is what we call endocrine resistant. These are the patients that recur during the period of adjuvant therapy or within the first 12 months after completion. So this group of patients was included in a different set of studies that actually also improved the results, but you can clearly see by looking at the PFS there that the numbers are different. These people have different outcomes in this situation. But again, the introduction of the cycling inhibitors in this group of patients doubles the PFS, again showing consistency in improving the outcomes in patients with hormone receptor positive disease. So certainly a revolution that needs to be taken into account. And here are 2 examples to make one specific point that I think we haven't been able to actually think about it too much. These are results from the Mona Lisa 2 trial that shows what I showed you, 25 months versus 16 months with the endocrine therapy, the combination better than the endocrine therapy alone. But look at the Monarch 3 results on the right-hand side of the study. And the point of this study that has a long follow-up. Look at the blue curve. You have a 29 months median PFS, which is by itself impressive, a lot better than the control arm. But look at the tail of that curve. You see that 8 years down the line, you remain with about 15 to 20% of the patients without progression. This is absolutely fantastic. We had never seen this before. Yes, we have seen this before. We have seen this with HER2-positive disease that Sarah can speak about a lot better than all of us. But certainly, this is showing us that we're changing the natural history of this disease. 8 years down the line, there are about 20% of these patients that still have not progressed to first line. My question is there a group of patients within this group that may be cured of this disease? And let me be the first one to tell you that maybe we're starting to generate treatment that actually may be able to cure some of these patients with metastatic hormone receptor positive disease. Okay? So within this concept, data from Mona Lisa studies was presented or will be presented tomorrow, showing exactly the same thing. Long-term follow-up of these first-line therapy studies that have sensitive disease actually showed results that tells us in a very consistent way that we're really changing the natural history of these patients. The challenge will be to identify who are the patients that really benefit from these treatments and obviously treat the other group of patients in a better way. But certainly there is no question for me that this is a revolution that we're actually witnessing at the present time. And these are the results both for the sensitive and the resistant group of patients and the trials on the overall survival. And you see also consistent, some of these trials show significant results, statistically significant results. Some of the others are clinically meaningful, but certainly the point of the slide is to show you that not only PFS, but overall survival is being impacted in a very significant way when we add cyclin inhibitors to endocrine therapy. This is just to compare the Monarch 3 results with the Mona Lisa 2 results, Monarch 3 with abemaciclib, Mona Lisa with the ribociclib. And the point here to make is that if you look at the median overall survival, we're talking about 67 months. We're talking about 65, 64 months of median overall survival. And if anything, if you look at the control arm of these trials, 54 and 51, this is better than the usual 40 months of median overall survival we used to get in the management of hormone receptor positive disease. So in spite of the control arm actually performing better than where we are expecting, we still have a significant overall survival benefit. So these results are extremely exciting. Obviously, we have toxicity to consider. This is the chart talking about palbociclib, ribociclib, abemaciclib. Note the different schedule, palbo and ribo, with 3 weeks on and 1 week off treatment, abemaciclib with a continuous daily dosing, neutropenia being the main side effect associated with ribo and palbociclib, diarrhea being the main side effect associated with abemaciclib. In general, all these toxicities are necessarily need to be considered different, but are manageable in clinical practice in a general way. The important concept here is that adding this toxicity implies for us as clinicians to work differently. This is not just prescribing tamoxifen, prescribing an aromatase inhibitor and telling the patient come back in 3 months and we'll see how you're doing. This implies in looking at blood tests, looking at EKGs, and following these patients, particularly in the early setting of the treatment, in the first 4 to 5 months, because that's where the toxicity actually shows up, and that's where we need to make those adjustments. And main point of this slide is that doing these dose adjustments, we do not compromise the efficacy of the drugs or the combination. So extremely important information. We need to recognize the adverse events, but managing the adverse events with dose reductions doesn't compromise the benefit of the treatment. Here you have, in the endocrine-resistant results, very consistent data, both from Monarch 2 and Mona Lisa 3, showing PFS benefits, doubling the PFS in both situations. The population of patients here are not necessarily exactly the same. And the overall survival also, okay, improving when you treat the more resistant patient population in second line in this kind of setting. Importantly, and this brings the point, that if we select patients for treatment in this kind of scenario, it's very, very critical that the new biology that we are recognizing in these patients with hormone receptor positive disease, that until very recently we were treating as if we're all the same, because we didn't have that many alternatives: tamoxifen, aromatase inhibitors, and fulvestrant. Okay, and that was it. Now we have not only the knowledge of different biology in different situations here, but we also have different treatment alternatives. And in this particular trial, the investigators actually did two things, as we were mentioning a few minutes ago. The first one, they selected a group of patients that had a very early recurrence. These are the resistant patients. They recur during the adjuvant therapy or within the first 12 months after completion. And the second selection criteria that they applied here is they selected a group of patients with hormone receptor positive disease but had PI3 kinase mutations. So they use a molecular biomarker to select this group, and they use a clinical feature in order to select these patients for these studies. And what they did, we know that 2 drugs, cyclin inhibitors and endocrine therapy, are better than 1 drug, endocrine therapy. Okay, and what they did is they used 3 drugs instead of 2 drugs. And I would like to call your attention to the lower graph that you see there in the right-hand side of the slide. In the orange curve, you see the standard treatment with a cyclin inhibitor and fulvestrant. These are resistant patients. What you would expect here is a longer PFS, as we expected with the sensitive patients. But in this group of patients, the PFS of a patient treated with palbociclib and fulvestrant was 7 months. Only 7 months. And even in this hard-to-treat patient group, if you add a 3rd drug specifically to the patients that have a PI3 kinase mutations, you increase the numbers significantly, okay, from 7 to 17 months of PFS. A very significant improvement again. So patient selection, critical, and combination of therapies are the main 2 strategies that are moving this field of hormone receptor positive disease forward. Amazingly, the survival was also positive in this trial, showing differences that are statistically significant from 27 months of survival to 34 months of survival in this very hard-to-treat patient population. But the most important aspect of this trial are what I mentioned a few minutes ago. Patient selection by clinical criteria and patient selection according to molecular abnormalities actually is helping us designing a better treatment, a more personalized treatment with very improved survivals. Obviously, this has toxicity, and when we're talking about blocking, inhibiting the PI3 kinase pathways, you have to remember hyperglycemia, stomatitis, diarrhea, and sometimes ocular events along with rash are the things that we need to follow. And probably we will be discussing this in the next section. Inavolisib has less toxicity as compared to the previous trials we have done with alpelisib, but certainly is something that needs to be placed into your consideration when you're designing a trial like this. Just finalizing this, it's extremely important for all of us to recognize that as we treat these patients, there are a number of different issues that are related to the clinical presentation of the patient, to the pathology, to the genomic profile of the patient, issues that may be related to patient preference, and obviously drug-related and toxicity issues that need to be taken into account. In this regard, this is what Sarah was mentioning, this is the art of medicine. We need to adapt this to a specific clinical situation. However, I love this study that was presented by Pedro and Rezavi in San Antonio here last year. And what these investigators from Memorial actually did is they took all these clinical characteristics that we actually consider in our daily practice, and they put together all the genomic information they generate with the impact sequencing platform they do in all patients at Memorial. And they put this into an artificial intelligence machine learning platform. And what they were able to do, remember the curve with the cycling inhibitors with the 24 months median PFS, okay, versus the 14 months? They were able to segment the 24 months curve in these 4 different curves. So instead of telling the patient you have a 24 months median PFS, by putting all these elements, all these factors together, analyzed by artificial intelligence machine learning, okay, they were able to segment patients in this setting in first line with a group that has only 5 months of PFS, a group that has 10 months of PFS, a group that has 20 months of PFS, and a group that has close to 30 months of PFS. Wouldn't it be nice when you start therapy to know if a patient is going to have 5 versus 30 months of PFS? Certainly, I would approach these patients completely different. Okay? This has been validated and probably is going to be available in a site for all of us to use. So this is extremely important and points to the future and how are we going to be selecting patients for therapy. Extremely important, and really, as I said before, I love this information. Obviously important to recognize ESR1 mutations that are very rarely seen in early patients, and either because of disease progresses or because of the therapeutic pressure we impose on these patients, we select patients with cells with mutations, and we can see ESR1 mutations in up to 40 to 50% of patients as we move along with our therapy in this scenario. Looking at resistance, this is obviously becoming more and more complex because we have resistance developed to the endocrine therapy alone. And there you have the alternatives of using SERDs and ESR1 mutations showing up. You have mechanism of resistance specifically to cycling inhibitors, and we know how complicated that may be. It's a whole different discussion. And we may have resistance being developed to the PI3 kinase pathway. So essentially, the complex nature of what we need to discuss and how we're going to be developing treatments from now on needs to take into account the biology of resistant development, which is something that we're just starting to understand. In that regard, and as I mentioned a few minutes ago, if you look at what happens in the different available trials in this scenario, very clear message from this slide is that combinations are better than single agents. In a complex biology, as we are identifying, it's naive to believe we're going to be able to be successful just with a single strategy. And as we learned many years ago from tuberculosis, okay, you manage resistance and you treat patients better and you cure disease when you use combinations. okay? And this is what we're seeing in this slide. Combinations in this setting, it's better. We know that 1 works, 2, it's better, and maybe 3, it's better, at least for some patients. So the message here is select patients according to the best criteria you can, and use combinations, and this is where we're going to be moving forward. And this is my last slide, and essentially addresses the treatment algorithm at the present time. So in a patient that has sensitive disease, progressed after 12 months of the adjuvant therapy, AI and a CDK4/6 inhibitor unquestionably is our first-line therapy at the present time. If you have a patient that has more resistant disease that recurs earlier, obviously fulvestrant and a CDK4/6 inhibitor could be something to consider. In this setting, in the first line, if you use genomics, you can use maybe fulvestrant, palbociclib, and inavo if you have a PI3 kinase mutations, or potentially, we didn't discuss this specifically, as you may know, at ASCO, the SERENA-6 trial was presented that suggests that detecting a ESR1 mutation and addressing this patient early with treatment with combinations with a new SERD may have a significant impact in the results. So certainly, genomics coming into the first line, helping us select the best treatment according to what findings do we have. If the patient progresses, then we have a number of different alternatives. And I find this kind of situation absolutely fantastic and looking forward for all the trials that are going to be available in this setting. Genomics are important because you need to classify if the patient has an ESR1 mutation that confers resistance, or if it has a BRCA1 mutation, or if it has a PI3 kinase mutation. Because all those abnormalities, if found, can influence the way you're going to be managing this patient specifically. And obviously, there is a large proportion of patients that is well-type that you do not have an abnormality to follow. So essentially, this creates the challenge of how we're going to be managing these patients from now on. So essentially, I feel this is a fantastic field in the area of breast cancer from now on. And going back, I handled to
Excellent.
Sarah.
This was a beautiful presentation, Dr. Barrios. And what I'm going to say is let's move on to Dr. Teplinsky's presentation, and then we will have questions and discussion at the end. I just want to remind everyone online and here, please do submit your questions. We're going to do some rapid fire at the end after Dr. Teplinsky's presentation. So with that, we have a case. Do you want to present it really?
Yeah, I can present it. So I'm going to try to move quickly through this so we have time for questions. So our case continues. We have Diana. She's a 58-year-old postmenopausal woman. We agreed she has high-risk disease based on her features that we've discussed, and she agrees to going on an adjuvant CDK4/6 inhibitor and endocrine therapy. And so she's completed chemotherapy, radiation. She started her endocrine therapy, and now she's coming into the clinic before starting the CDK inhibitor. So in your experience, what are the biggest questions or concerns that patients have related to adjuvant CDKs? Toxicity, frequency of visits, burden of therapy, so meaning adding another medication, cost, or all of the above? Okay. So pretty much all of the above. That's almost 3/4 people on the other toxicity. So we're going to kind of go into this. I think this is something that physicians, providers, patients all worry about, and it's important to talk about all of these things. So we have to, as we think about using adjuvant CDK4/6 inhibitors, we really have to consider our side effects. So when we think about ribociclib and abemaciclib, there are side effects that are similar to both, but then each of them have their unique toxicities that we have to pay attention to. So on the orange are the toxicities of abemaciclib, and the lighter color is going to be grade 3 or higher adverse events, and then the blues are ribociclib toxicities. So myelosuppression, neutropenia are side effects to both ribo and abemaciclib. With abemaciclib, we see more GI toxicity, so pretty significant rates of diarrhea, abdominal pain, vomiting, comparable rates of hot flashes. And then with ribociclib, we're going to see a little bit more of hepatotoxicity, so transaminitis. And then you can kind of go through some of the side effects on the bottom as well. With ribociclib, we also have to monitor EKGs upon starting, so that adds a little bit as well. So both medications require monitoring, but the monitoring is different based on their side effect profiles. So at the top, you can see the blood work that we need to monitor, and specifically with CBC, we're monitoring at the start, and then we continue to do that every 2 weeks for the first 2 months, and then it goes to monthly, and then it's clinically indicated. So a lot of that's going to depend on where are we starting from, how often they're coming in after those 3 to 4 months. And then you could see ribociclib, we're going to do it monthly for those 6 months. We monitor liver function as well, so it's really important as they're coming in for their CBCs that we're also doing their liver function. And then we do monitor for symptoms of interstitial lung disease and pneumonitis, which while rare can happen. And you can see here for ribociclib, you need an EKG prior to the start, and then day 14 of cycle 1, and then it's clinically indicated. With the abemaciclib, they do not need EKG monitoring. Similarly, electrolytes with ribociclib, monitoring all of our patients for infection, and again for thromboembolic disease. So there are differences that are important to know. Now, dosing is also important and differs a little bit with ribociclib from metastatic to early stage disease. So for abemaciclib, the starting dose is 150 milligrams twice daily, and then you can dose reduce to 100, and you can dose reduce to 50 as needed for toxicity. With ribociclib, the starting dose is 400 milligrams daily, and this is taken as 21 days on and 7 days off. And an important point is that that's different than metastatic disease, where we use 600 milligrams. And then they can dose reduce to 200 milligrams for toxicity. We did see at ASCO this year the results of the TRADE study, which is a phase 2 dose escalation trial of adjuvant abemaciclib. So most patients really have a hard time with 150 milligrams. Not all, but many patients, and a lot of us have started to actually start at a lower dose anyway, just for toxicity concerns. And so what TRADE did was they actually started everyone at 50 milligrams twice a day, and then had a dose escalation. So 50 milligrams for 2 weeks, 100 milligrams for the next 2 weeks, and then increased to 150 milligrams. And what they found here with TRADE is that the dose escalation, rather than a de-escalation, but the escalation allowed more people to reach the target dose. They had fewer discontinuations, and that actually may prevent or delay toxicity. And I will say that patients feel very comfortable with starting at a lower dose. They're worried about the diarrhea and the GI toxicities, especially if they've had chemotherapy and they remember the diarrhea and the GI toxicity from chemo. And so kind of having that option to start at a lower dose is really well received with patients. So let's look at Monarchy, which is our adjuvant abemaciclib study that we've heard about. And an important point here is that dose modifications were common and they occurred early. And 42.5% of patients did require a dose reduction, but what is important is that it was frequently in the first few months. And so if they kind of make it past the first few months, they seem to get in a groove where they can continue on abemaciclib. And you can see here that patients, 30% discontinued abemaciclib early, and you can see what are some of the reasons for dose holds and dose reductions and interruptions, and all of that is really diarrhea, neutropenia, and leukopenia, and fatigue. And I think that's something you would echo in what you see in clinical practice. With Monarchy, what we know is that there's a low threshold for dose reduction. So we shouldn't be afraid of reducing the dose with our patients. It improves adherence, and we still maintain the adjuvant CDK4/6 benefits. Although not on this slide, recently we saw the study was published in JAMA Oncology, which was the AMELI study. And this was looking at metastatic ribociclib, 400 milligrams versus 600 milligrams, showing that starting at 400 milligrams, while not meet non-inferiority, had a very similar progression-free survival. So just more data to show that a lower dose, we shouldn't be afraid of that lower dose, and we should be able to talk to our patients about it. I will say that often patients worry that if they dose reduce, they're going to have worse outcomes. And so I think it's our responsibility to make sure to share that data that's saying, you know what, we have data that the benefits are going to be maintained despite a dose reduction. Similarly, we saw the landmark 4-year analysis of NATALEE, which showed similar things, that ribociclib dose reductions lowered occurrence of AEs and discontinuations. And again, so just not being afraid of that dose reduction. Another analysis here is showing that ribociclib dose reductions does not affect efficacy. You can see, looking at disease-free survival, the curves do not separate with or without a dose reduction. Diarrhea management is really, really important. The best thing is to be proactive. So not saying, all right, let's see if diarrhea develops and we'll deal with it then. But really making sure the patients at home have over-the-counter or antidiarrheal medications available before they start therapy, telling them how to use them, discussing appropriate dietary changes, and having a plan for the patients to call to the clinic if toxicities develop. So again, being really proactive with that. So again, at the first sign of loose stools, they should immediately start an antidiarrheal. Sometimes people want to wait and hold off and see what happens, but really at that first sign of a loose stool, increase the fluids, and they should be calling the office to see, because sometimes if they're having a lot of diarrhea, I may bring them in for some hydration or blood work just to make sure they're not getting really dehydrated. Again, it depends on the patient. And then there are very clear dose modifications based on the toxicity and the grade of the diarrhea. So typically for grade 1, no dose modifications are required. But remember, grade 1 diarrhea is 4 episodes a day. And for some people, for most people, I think for all of us, 4 episodes a day of diarrhea is a lot, especially if you're trying to work, you're trying to be a parent, you're trying to do all these things. So I think that the grades are really important, and you can see them here, when to hold treatment, when to stop it, when to discontinue. But I think just being mindful of what the implications are of multiple episodes of diarrhea are to our patients. In terms of managing hematologic toxicities, I think this is a really helpful schema here about what to do, but generally for grade 1 to 2, no dose modifications are required. For grade 3, we're going to suspend the dose until the hematologic toxicity improves. And then for recurring grade 3 or grade 4, we suspend the dose, but then we want to dose reduce. So this is a really helpful schematic to follow as we're working in the clinic. And I think that bringing in our nurses and our APPs can be really helpful in guiding us and working together as a team to manage that toxicity. One of the big things is in terms of how do we optimize adherence and persistence to these medications, right? Our patients have gone through so much. They've gone through chemo and surgery and radiation, endocrine therapy. They may be in premature menopause. And now we're adding here 2 to 3 years of a medication that can be hard for some people to really tolerate. So I think understanding, we talked about this earlier, understanding why they're taking the medication, what the benefit is, what are the tangible improvements based on the data that we have. But then there's multiple factors. So you look here, it's adherence is not just the patient or the therapy, right? It's the healthcare system. It's the social and economic things. If patients are having a lot of diarrhea and they have to go to work, they're not going to take that medication, right? So there's so many factors that we have to be talking and thinking about. Okay. So what can we do to improve adherence? I think you can break this down into therapy-related interventions and then patient-related interventions. So for therapy-related interventions, simplify as much as we can, educating and being proactive and providing clear instructions. This is what you're going to do if you have diarrhea. And again, we talked about this, not saying see you in 3 months, right? They're coming in often, making sure they have a plan. Who are they going to call if they have side effects? What are we going to do when they call the office? Monitoring these AEs, and then making sure that everyone on the team knows this is what the side effects are. Because again, if they're calling, they want to make sure they're talking to a team member that is familiar with the side effects of these medications. So really, team education is important. And then on the patient-related interventions, I think really the big thing is the conversation. Having that dialogue of, yes, these are side effects, but there's a lot we can do, making sure the patients feel comfortable enough to call. And then there's a number of patient education materials and digital tools, remote monitoring tools. There's a lot happening now with clinical trials, really utilizing, electronic tools, remote monitoring tools. So how do we make it simpler for the patients to notify us that they're having diarrhea, right? A lot of times tell you calling the office and now you're on hold and now it's been 30 minutes and you've just given up and hung up the phone. So is there a way for them to communicate a lot of these things remotely? But again, I think patient education and communication and open dialogue. So let's come back to our first case. We have, again, Diana here. I think, Sarah, do you want to go through that now?
Sure, absolutely. So it was beautiful. Thank you so much, Dr. Teklinski. So much to consider with these patients. So I think considering our time, I'm going to actually take us through, before you do this, I'm going to take us through a number of questions that came through because I think they're more important. They're going to get to the questions that we had planned for this. Okay, so we have 8 minutes because everybody wants to get to their next meeting or the bar or their bed. And so I am going to do rapid fire. So your task is 15 to 20 seconds, no more than. Shorter, better. Okay, so Dr. Barrios, how does overall survival impact your management in the clinical setting, in the adjuvant and metastatic setting? Does overall survival weigh heavily on your recommendation?
Yes, actually, the response is yes. I think it's extremely important to consider overall survival. And as I mentioned, we need to start thinking maybe in some patients and the possibility of curing metastatic disease.
Okay, perfect. Eleonora, for a premenopausal woman, premeno, N1, so let's say 1 lymph node, recurrence score is 12. Do you consider using adjuvant ribociclib in that situation? And would you omit chemo?
So I would consider using adjuvant ribociclib. We have good data on efficacy in the N1 population. We know that the efficacy does not differ based on menopausal status. In terms of omitting chemo, I think I would really push for the offset study, which exactly looks at this question of safely omitting chemo or not. In the absence of the offset study, I think our standard of care right now is still chemotherapy, so that would be my approach.
Okay, perfect. Kamel, do you consider adjuvant ribociclib for a postmenopausal N0, recurrence score is low, grade 2, but Ki-67 is high? They would have gotten onto Natalie. So N0, recurrence score is low, let's say 12, grade 2, but the Ki-67 is high. Would you recommend adjuvant ribociclib?
I would.
Just discuss it with patients and see what they...
Absolutely.
Okay, that you win for the shortest answer. Okay, very good. We have a harder question now. Dr. Barrios, what role does ctDNA testing have in the adjuvant or metastatic setting? Adjuvant first.
It's going to be a revolution. We know a number of patients do have ctDNA positivity. That's a technology that will improve as we move along. And certainly, I believe it's going to guide our therapy in the adjuvant setting. In the metastatic setting, will definitely help us. I think that the SERENA-6 trial is not necessarily about bringing in a new SERD, being more effective in that setting, but it's telling us that we will be following our patients not by CT scans or by PET scans, but probably by ctDNA as well. So I think that's going to change the way we manage patients overall.
Are you doing it today or you're waiting a little longer?
No, I think we need more data. I'm talking about my perception of the future.
Thank you. Dr. Hussain, how much of a limiting issue is polypharmacy in your practice? for patients with hormone receptor positive early and late disease? And does that influence your treatment recommendation?
How much? Can you repeat the question again?
Okay, polypharmacy, using multiple drugs. How much does that influence which CDK4/6 inhibitor you choose?
Really, in the adjuvant setting, when it comes to the choice of CDK4/6 inhibitors, I think both have great data. The most important factor for me is patients who have extremely high risk with a lot of nodal involvement. I try to push for abemaciclib, but at the end of the day, if I am not able to get them through abemaciclib safely, I think ribociclib is a very reasonable option. So quality of life and symptom management is really...
Are you worried about QTC prolongation in patients taking multiple medications with the use of ribociclib, or does that not weigh as much into your decision making?
Of course, it's a very important factor, but it depends on what medicines they're on. So yes, I do the baseline QTC interval. If it's above a certain limit of 480, I think that's a complete no, and it will go to abemaciclib.
Perfect.
One educational point, I think that we need to follow new medications that other physicians may prescribe to our patients that are on the adjuvant setting that sometimes they do not tell us. So that needs to be followed.
Absolutely. Huge education point for our patients. All right, Dr. Teplinsky, can you switch CDK4/6 inhibitors in the adjuvant setting due to tolerability? What do you do in your practice? No data, art of medicine.
I think you can switch. A lot of it depends on the toxicity and which one you started with, but I've switched several times. People have really unbearable diarrhea or they develop hepatotoxicity from ribociclib. We do want to make sure that that side effect resolves before we switch, but I think it is an option, again, data-free zone, but something that we can do in the clinic.
That was beautiful. I'm going to ask you another one. So is it acceptable, you said it's acceptable based on all the data you showed, to start at a lower dose of a CDK4/6 inhibitor in the adjuvant setting? That beautiful trade data provided us reassurance. Can we apply that in the metastatic setting for patients in whom we're worried about tolerability and apply it to ribociclib?
Well, I think we have the Amelie study, which did look at starting at 400 instead of 600 in the metastatic setting. So again, that study did not meet non-inferiority for 400, but when you look at the numbers, the duration of response and progression-free survival was similar. And so I will say I often start at 400, especially in patients who may be older, who may be on multiple medications where we're worried about it. So I think it's okay to do that. Knowing your patient, I mean, that's that shared decision-making where you're going to sit in front of them and say, here are the side effects, what are we doing?
Perfect. Carlos, are there concrete criteria for the definition of endocrine sensitive versus resistant? You presented some very nice data. Are there concrete data that we can all rely on?
Absolutely not. I think that what we have been doing, and we generated this information in the ABC group from Europe, are clinical expert opinion criteria that actually, when applied to clinical practice and clinical research, have stand as valuable. Okay, we do have different PFSs when we apply this criteria. However, this is a clinical reflection of a biology that we do not understand as of yet. Okay, but for now, for clinical trials, these criteria actually work.
Perfect. All right, Kamel. Have the pre-specified subgroup analyses of Monarchy and Natalie shown any differential benefit of CDK4/6 inhibitor across the subgroups that they have analyzed thus far?
Yeah, so today's poster, the one that broke it down by the nodal involvement, N1, N2, N3, I think that was quite impactful to see that the benefit is maintained regardless of whether it's N1, N2, N3, and this is what we have shown exactly in the Miami Breast real-world data, where N1 is regarded as a lesser beneficial subgroup. So it's a good reminder, but definitely with the higher number of lymph node involvement, we do see that the benefit seems to deepen over time. So I think that's quite reassuring to see.
Very reassuring. All right, one more question, then we're off the hook. It's to the bars or the bed?
To the bar.
Carlos, first. Question on the, sorry, I lost it. Oh, Highly refractory. We had a couple questions on this. Patient whose disease recurs within 6 months of starting adjuvant endocrine therapy. Based on right choice, would you give them a CDK4/6 inhibitor or would you go straight to chemo?
Difficult question. I think that it depends on the clinical situation. Sometimes when we discuss this in a tumor board, it's you just consider the clinical trial, but looking at the patient, sometimes you make different decisions. So the art of medicine that was mentioned before is important there. I think that it is reassuring to be able to treat these patients with a CDK4/6 inhibitor, but certainly these are harder to treat patients, and considering chemotherapy in some cases, even an ADC would be a consideration.
Amel?
And even though we said there is no hardcore set that says who is endocrine sensitive and refractory, but this is a patient that definitely meets criteria for primary endocrine resistance.
Absolutely,
Yes.
absolutely. And Eleanor, the last one, is there, if on the other end of the spectrum, if you have a patient who comes back 15 years after completing their adjuvant endocrine therapy with metastatic disease, do you ever omit the CDK4/6 inhibitor and just go with endocrine therapy?
So, I think we do have data from the Sonia trial, believe, and others, looking at just using an aromatase inhibitor up front and then, adding in that second, the CDK4/6 inhibitor, a second line. So I have done that, again, depending on patient age, comorbidities. But I think that there are some patients who probably do not need, based on the data we have, that CDK4/6 inhibitor up front. But we're still really refining who those patients are going to be.
Excellent. This is wonderful. So I'm going to ask our audience to reflect and share your insights, answer this poll. And this is the same question. I will not read it back to you. So please use the QR code. Our online audience, please answer this question. Okay, there we go. Perfect. Excellent. So still, I think I received helpful guidance in all of the above areas. I love it. Let's keep them coming. Let's keep them coming. That's great. And thank you so much to our panelists. That was absolutely wonderful. Thank you to our online audience and our in-person audience. And enjoy the last couple of days of San Antonio. It was great to see you here. Thank you.
Fantastic moderation.